Welcome to this podcast. This interview is with a doctor that has an extensive experience and background in this area, this topic of child abuse, child sexual abuse. Dr. Tim Brewerton has a distinguished and accomplished background and active practice, really ranging from a medical doctor to also working as a psychiatrist. And he'll get into a little bit more specific his career and what his background has took him through. He and I met each other serving in our community as neighbors. We discovered that we were neighbors serving the Exchange Club, which is, by the way, a national organization, a national nonprofit organization that does a lot of good work in communities and fundraising. For example, one of the committees that Dr. Brewerton and I serve on is a child abuse prevention committee. And we've been able to coordinate and serve and support many different organizations in our local area that support families through these types of circumstances and provide support to children as well. We realized that we had this common interest in protecting and in serving and supporting children from abuse and through recovery after abuse. So I'm going to jump right into you getting to know Dr. Brewerton. So thank you so much for joining us today, Dr. Brewerton.
Thank you, Laura. It's a real pleasure to be invited to participate on your podcast.
So tell us a little bit more about your background. I just
Yeah.
barely touched the surface.
Okay. Well, I've lived in South Carolina for 36 years now, so it's really home. But I'm from Louisiana originally. Grew up in Baton Rouge, went to LSU undergraduate, met my high school sweetheart in Baton Rouge, whose father was a psychiatrist. And it really kind of turned me on to the idea of becoming a psychiatrist. And her mother was a psychologist as well. And it kind of introduced me to a whole nother world and way of understanding, because I was always curious as a kid about why people did what they did. And so I went to LSU, did pre-med, studied zoology, and went to Tulane Medical School, knowing I wanted to be a psychiatrist. And that really didn't waver. And then I went to the University of California in San Francisco, which was quite a different kind of culture for a Louisiana Cajun boy. And that was really quite an education. And from there, I worked for the Public Health Service in Hawaii State Hospital. But the research bug had bitten me as a resident in California. And I went to the National Institute of Mental Health and did a research fellowship. And there I studied the role of serotonin in eating disorders. And I was very much a biological psychiatrist, if you would, kind of anti-psychoanalysis. Because the new neurobiology was kind of emerging in the world back in the late 70s, early 80s. And so I had the opportunity to go to NIMH, and I did. And I studied there 3 years and did a lot of research, and came to the Medical University of South Carolina in 1987 to found the first eating disorder program at the new Institute of Psychiatry. And that's where I really kind of thrived and continued my work, but focusing mainly on evaluating and treating eating disorders. Now, after just 8 months of coming to Charleston, I was referred a case of a woman from a family physician on the faculty for the treatment of severe binge eating, depression, and obesity who had impending diabetes mellitus. And so I started treating her, and I started treating her binge eating, and I started treating her depression, and Prozac had just come out. But there were some very peculiar things about her story and her history that really perplexed me. For example, I would ask her if she had ever been married, and she says, well, I'm not sure. I'm not sure if I've been married. And why is that important anyway? I'm here to lose weight, because that's how she processed the referral. So I went on to the next thing and asked her about what growing up was like, what her childhood was like. And she said, well, I don't know. It seems like I need to go back and rescue that little girl. And that was a very peculiar answer. And I thought I'd kind of seen it and heard it all, training in San Francisco and NIMH and Hawaii State Hospital. And I'd never really heard that one before,
Mhm.
talking to, about yourself in the third person. And the more I would persist, she would again say, well, why is that important anyway? I'm here to lose weight. And so we would continue on, and around the fourth session or so, her depression was starting to get better, and I would come around to those questions that she had avoided or answered in that peculiar way. And suddenly one day she completely changed her countenance and uncrossed her legs and leaned up and in the voice of a child said, "Why don't you just leave us all alone?" And I had to pick my jaw up off the ground because I had realized that I had met my first case of multiple personality disorder.
Mm.
And I asked at that moment, how many of you are there?
Mm.
And little Janie started telling me the answers to all the questions that I had been asking Sylvia over the last few sessions. And so it was quite an unbelievable experience. And my experience treating Sylvia for the ensuing 4.5 years to full integration really opened my eyes to the profound effects that early and severe childhood abuse, particularly childhood sexual abuse, can have on human beings and the mind and the brain. And at that time, there wasn't really much known about the role of trauma in eating disorders. And so part of what I did, just more the research hat, was to begin to inquire about that. And I aligned myself with the National Crime Victims Center at MUSC, and we started looking at that. And I was able to get questions about eating disorders in the third wave of the National Women's Study. And we found that uh, prior sexual assault and physical assault and attempted sexual assault were very high in people with eating disorders, particularly bulimia nervosa and binge eating disorder. And also, the rates of PTSD were extraordinarily high. And this was a non-clinical representative sample of United States women, randomly selected. And the rates of lifetime PTSD were on the order of 37% in those with bulimia. And so this was really big news in the field. And we eventually published those works, and I've continued to do that kind of research. And one thing leads to another. And for me, it led me to go back and do my child adolescent psychiatry training as an associate professor at MUSC, and then also to become a forensic psychiatrist. And so I've continued my research and clinical work around the issues of trauma, PTSD, dissociative disorders, and eating disorders, and other psychiatric comorbidity. So I'll stop there and let you, sit with that and ask me the next question.
Yes, yes.
That's a lot.
Well, it is a lot. It's been very interesting to see how your from your introduction to like a childhood girlfriend,
Yeah.
high school girlfriend, led you to pursue this area, and then you were really on the research side, as you said.
Mhm.
But thank goodness you began to make that connection, because I know for ourselves and for my story, which you're familiar with, for our daughter's story, it was her eating disorder that we treated first.
Yes.
And she had had her outcry where we heard about after a suicide attempt, we discovered and heard about her sexual abuse, but we were most concerned with the eating disorder.
Mhm.
And in hindsight, I think as a parent and perhaps even as an adult listening to this podcast or watching this, you would probably connect the dots as just being an assumption. But at that time that you were discovering this and working on this, it was not connected. It was
No,
not connected whatsoever. And you
no,
were
it
at
wasn't.
just that beginning stage.
Yes, and that's amazing, and but not terribly surprising to me,
Right.
because often, trauma and PTSD can present in any number of ways. It can be depression, it can be suicidal attempts, it can be an addiction, it can be any number of things, but eating disorders are certainly one of them. But this was not at all recognized back when I first started in the field. In fact, there was quite a lot of resistance in the field to acknowledging the role of trauma. Um, and a lot of times, parents of those with eating disorders would be defensive that I was accusing them of abusing their children. And it's not that all eating disorders have trauma as their core. And, psychiatric disorders are complicated, and there's always an interaction between genetic or biological hereditary factors. And most people don't know that eating disorders are highly heritable, but also environmental factors like trauma play a major role, particularly in those that have binge purge features, as well as sociocultural factors. Most people attribute eating disorders to all sociocultural factors, but actually that plays relatively minimum role. And it's more the genetic, hereditary, and environmental factors that are, if you look at twins that are not shared growing up. And so one twin can be abused and have trauma and another not. And it's more likely the one who is abused that will develop problems like an eating disorder.
Mhm.
So, but yes, now it's kind of become, because of the research that's been done, and other people have replicated our work many times over. It's because of that research that clinical care advances and science advances and clinical care changes.
Mhm.
And but there was a time where people would be admitted to eating disorder treatment facilities, and they wouldn't touch the trauma. They would only treat the eating disorder, and they would say, well, you're here for your eating disorder and you can deal with that when you're an outpatient. But that really was not good advice. And people would go out, their eating disorder might be better for a while, but then because the trauma was undigested or unprocessed, if you
Mhm.
would, um, they would tend to relapse because there are connections between these disorders. They're not discrete and compartmentalized entities that don't have anything to do with each other. And one of the biggest drivers of comorbidity or co-occurrence of a number of different disorders together uh, is trauma, underlying trauma. And so a lot of times eating disordered behaviors or ways to cope with or adapt to the effects of trauma or PTSD in particular, ways to help one calm down, ways to help avoid thinking about what happened, ways to soothe, self-soothe. It becomes food in particular in great quantities, much like substance abuse, becomes a way to self-medicate.
Mhm.
But any number of behaviors, even starving yourself and compulsive exercising, can be used to self-soothe and
Right.
self-medicate.
Right. And control. Tell us a
Yes.
little bit
It
about
gives
for
you
those.
an illusion of control, though. It doesn't give you
Correct.
real control, but it's an attempt to control. Yes.
Yes, correct, correct. So tell us a little bit. I was fortunate enough that we had a family friend, a dear family friend that my daughter and I knew who had walked through an experience with an eating disorder and had been placed at centers that when we confronted this ourselves, I was able to call her and say, help us. What would you recommend? Where would you recommend?
Yeah.
What advice would you give to anyone listening? One, if they suspect that a child has an eating disorder, what should they do? And then two, what types of, services, treatments are available?
Well, I think first I'll start with what not to do, which
Thank
is
you.
to avoid it.
Yeah.
And one of the big premises in treating PTSD and trauma-related disorders is to avoid avoidance. It's one of the major principles of cognitive processing therapy. And so it's natural to kind of want to avoid uncomfortable topics,
Yes.
things that might upset your loved one. And you certainly mean them well and you don't want to upset them, but sometimes you have to talk about things that are of concern, like if they're not eating or if they're binge eating or you suspect purging or some other drastic change in their behavior. It needs to be addressed. A good place to start is with your primary care doctor, your family physician or pediatrician. I think most have become versed, at least in the major symptoms of eating disorders. And it's important to have medical evaluations. Eating disorders are one of the biggest killers. They have the highest mortality of many psychiatric disorders. The only thing higher mortality is opiate use disorder now, with the fentanyl epidemic and the opioid epidemic. That's the highest, higher than anorexia nervosa. But anorexia nervosa is next in terms of lethality. And there's all sorts of other kind of medical complications and psychiatric complications and comorbidity, as I've mentioned, that really need to be addressed. And the other big thing here is that eating disorders are treatable. And you know that from your own experience, even though it seemed really, dire and you were desperate, you got help. And this is how the trauma was discovered, as I understand it. Is that right?
Yes.
Yeah.
Yes.
And so that's often the case. And so people need a caring, sympathetic, compassionate ear. And I think now most people in the field are alert to the possibility of deep trauma and other comorbid disorders like depression and PTSD and sometimes substance abuse and ADHD. It can be any number of things that we know are highly linked to eating disorders. So reach out, get help. There's so much information and help out there now. And I think one of the big obstacles is a sense of shame
Mm.
that people have, and often families have.
Hmm.
Um, Somehow parents feel like they've failed, but no, it doesn't represent a failure at all. Not addressing it is really more the failure.
Yes, yes, indeed. Yes, you do. You feel ashamed, you feel responsible,
Yeah.
you feel helpless because you
Yes.
aren't able to solve it.
Yes.
And so your advice on who to reach out to and talk to
You
is
feel
really
guilty for failing to protect,
right.
right?
Yes.
When
Yes.
abuse is involved. Um, and parents are doing their best. And sometimes things happen a lot. They happen quite a lot. Um, you can't, you know, watch your child 24/7 until they're, grown adults.
Right.
Uh, and the other thing is sometimes um, it's who you least expect in terms of who the perpetrators are, the abusers are.
Yeah.
93% of abuse of children involves people you know.
Yes.
And I think that's worth saying many times over. It's not the stranger. A lot of times people are concerned about the strangers, and it's not the strangers. It's the people you know who are the most dangerous, actually.
Yes, yes, that is absolutely true. And that is That is so shocking for folks because we
Yeah,
want to trust other people. And,
yeah,
in this podcast, we do some education on how to identify, how to prevent, and lessons that we've learned. I know Dr. Brewerton and I share an interest in an organization called Darkness to Light,
mm,
which provides online training and support and education. So if you're listening and you are in any way a steward of children, then that is a program that you can become certified in, which will help you to be more aware of how to prevent, how to identify, and how to report if there is possible abuse happening. But
yeah,
I know, in our case, it was the most popular dad in the neighborhood. It was the father of our daughter's best friend, and least likely, least
yeah.
likely suspected. But had I known some of the statistics and some of the things that I know now, I might would have asked a different question or handled things a little bit differently. But what I can do is share the information to help others as well. And I'm
Yes.
so thankful for professionals like you who are trained and have a commitment to others in this topic, to help them in their journey. So thank you for the work that you're doing, the good work that you're doing.
Yeah, and thank you. And as they say, it takes a village, and none of us can do it alone. And there is an enormously supportive network in this community. And you mentioned Darkness to Light. It was founded here in Charleston, started here. Another fantastic organization that I liaison with through the Exchange Club is the D. Norton Child Advocacy Center. And child advocacy centers, for those of you who don't know, are places where children can be evaluated in a kind of forensic way or investigative way who are suspected of having been victims of abuse. When appropriate, the police are involved, DSS is involved, but these are really highly trained professionals. There are two centers in the Charleston area, one in Charleston proper downtown and one in Mount Pleasant. And they do a fantastic job. They're nationally recognized. I've worked with them back when I was full-time at MUSC. Have done a little bit of research with them, but there are all kinds of resources out there to help that people may not know about.
Exactly, exactly. And hopefully we'll provide some of those through the show notes,
Yeah,
and reach out to me if you have a
yeah,
question about some of those resources, because I feel like in our several years of our journey of our daughter, treating our daughter's symptoms and her journey for healing, and then also me becoming certified to help pay it forward and help others,
yeah.
but then also my own just research, books, reading, watching things. Let's talk a little bit about, you have a very special project going on with your experience with Sylvia,
Yeah.
to help others. Tell us a little bit more about that project and what could we do to support you in that project?
Thank you for asking. Yeah, it's 36 years ago this month where I first met Sylvia in February of 1988, and I have to tell you that I've treated hundreds of patients in my career. I've been very fortunate, but my interaction with Sylvia was one of the most profound and transformative for me personally, but also professionally. And as I mentioned, um, I pretty much directed my attention to researching the role of child abuse and trauma in the eating disorder field, and feel like I've contributed to that. But also PTSD, dissociative disorders, comorbidity, and how they interface there. But one of the things that I did at the time when I was treating Sylvia is videotape and audio tape our sessions. People who have bona fide dissociative identity disorder, which was at the time called multiple personality disorder, they believe that they have different people inside of them. They literally believe that. And that's really the crux of the disorder, that identity alteration along with amnesia for big chunks of their life. And so there are parts of them out in the real world that don't remember the horrific experiences that they suffered. And it's a way of coping. It's a way of adapting. It's a way of surviving by developing these other entities early in life. It begins with very early and severe childhood abuse, usually starting before the age of 5. So Sylvia would say, "Oh, you don't know what you're talking about. That didn't happen." When I would tell her that she would switch and some of the things that she would say, I said, "Well, I can prove it to you. Just allow me to videotape you, and I can show you the tape, and you can see that you don't switch bodies. You're there one body, even though you think you're several." It was 7 alters in her case. And so she allowed me to videotape her and play back the tapes to her, and that made her convinced that she, in fact, did have multiple personality disorder, DID, now. And that really facilitated the treatment, and because it got buy-in from her that I knew what I was doing, and I knew what I was talking about. And I had used a lot of videotape in my family therapy training in San Francisco. And then I started audio taping as well, because I couldn't videotape every time. But it allowed me to pretty much collect over 95% of the entire therapy that I did with her over 4.5 years. And I've had that since transcribed over the years, and it's going to ultimately be a book. But I started using the videotape in addition to helping her therapeutically to show psychiatry residents and trainees that this disorder was real. Because back in the day, in the 90s, there was a ton of controversy that whether this even existed or not. And the myth was that it was rare, and that a lot of times they thought that it was being made up, or it was due to overly enthusiastic therapists who were implanting these ideas and implanting these memories, and that led to the whole false memory syndrome and false memory syndrome foundation, which is now defunct, because the data have clearly shown that this is a bona fide psychiatric disorder all over the world. It's been discovered and written about in every continent except Antarctica. And so the project that you're asking me about is a documentary film about Sylvia and her life and her treatment and her recovery, because that's one of the big messages here. And Sylvia really wanted other people to know that this was a real thing, a real entity, and that people could recover from it. And she ended up doing well, meeting a man and getting married and living a very happy life for her last 25 years. And she unfortunately died in 2016. But she really wanted this to become a film and a book that would help other people. And her heart was really in the right place. And so that's what I'm doing. And so we've interviewed several experts around the country. We have excerpts from the therapy that I did with her. We have excerpts from filming her widowed husband, her best friend. There's another patient with DID and binge eating also. And so this is a work in progress. If you're interested, you can go to sylviadoc.com, 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 and read a little bit about it. And if you are so inclined, donate to our cause. It started with a course to teach residents and other people, my trainees, because as a professor at MUSC, that was one of my major goals. It was to treat eating disorders, but also to teach people how to treat eating disorders and all the things that come with it. And that included DID and MPD and PTSD. And so I have a 5-hour course now that has 80 minutes of the therapy sessions, videotape sessions, showing her evolution of her treatment and ultimate integration. And that's at sharpenminds.com/Sylvia. sharpenminds.com/Sylvia. And that's a course for professionals and interested lay people to learn more about DID and child abuse and how it affects people and how it can be treated effectively.
Oh, thank you so much, Dr. Brewerton. I've had a chance to look at the website and excerpts of it, and this whole conversation has me encouraged. I'm
Yeah.
so encouraged by the progress that the medical and the psychiatric community is making and the culture is making.
Yes. Yeah.
In society, I find that we are becoming more and more aware and more acceptable to talk about and to seek solutions and treatment versus so many years ago where it was deny, deny, deny,
Yes.
hide, sweep under the rug. It was
Yes.
covered in guilt and shame. And I'm just really encouraged that not only are we evolving to understand the connections supported by great minds like yours, but we're also as a society being willing to say we need help and
Yeah.
let's find help together rather than to sweep something under the rug. So that certainly has been encouraging for me.
Yeah, I'm encouraged too, but it's been a slow process, and there's still a lot to do and a long way to go. But you're right, we have come a long way, and I think particularly the Me Too movement has helped things along to realize the reality of particularly sexual assault and its impact,
Mhm.
uh, particularly on girls and women, but not exclusively.
Yeah.
Boys are also very much a target, particularly the younger you are, the less there is a lopsided ratio, more of an even ratio of
Mhm.
girls to boys
Mhm.
who are abused. So, yeah,
Yes,
we've come a
indeed.
long way.
Indeed. Well, is there anything as we wrap up that we haven't talked about or covered that you would really want to recommend to those listening?
Well, a couple of things. I think most people have very distorted ideas about what DID is, and even a lot of professionals, psychiatrists, psychologists, mental health workers, get most of what they've learned from the media, from movies and TV, and that is completely wrong, completely distorted. And these are sensationalized, demonized versions of the disorder, which only further misunderstanding and stigmatization. And so don't believe what you see or hear in the media, uh, and seek out more reliable sources of information about these very, very serious disorders, which are much more common. For many years, people were taught that it was rare or didn't exist even. But now we know that DID, the prevalence of DID is about 1.5% of the population currently.
Mm.
Uh, and we used to think that childhood sexual abuse was extremely rare. When I was in medical school, the comprehensive textbook of psychiatry said that incest was extremely rare, occurring no more than 1 in 1.1 million people, which of course is ridiculous now because we know that 1 out of 4 girls on average have some sort of sexual assault, and that's usually during childhood or adolescence in 2/3 of cases.
Yeah.
And so, uh, we've learned so much about the reality of this kind of violence. And
Yeah.
so I would want people to, do their homework and not just be educated by the media because that's so-called entertainment,
Right.
right? That's not science. Um, the other thing is that we all have changes in our states of mind. We have changes in states of mind all the time, and DID is just kind of exaggerated version of state changes. We all have depressed states, we changes in mood, panic states, psychotic states, intoxicated states, sleep states, dream states. Um, it goes on and on. And if you're really interested in reading about this, one of my mentors, Frank Putnam, has a great book. It's called The Way We Are. And it's really a compendium of what we know from a scientific point of view about states of mind and changes in states of mind. So I think those are two things I will leave you with.
Leave everyone with. Well,
Yeah.
I so much appreciate your time today. Thank you so much. This has really been educational and encouraging, and I appreciate your work that we get to do together and much of the work that you continue to do in this arena, in this
Yeah,
area.
thank you very much. And
Thank you.
thank you for your work too, because this is a great venue to help people get educated about a very
Absolutely.
important but not talked about enough topic.
Yes, yes. As you and I have talked before, I feel so strongly that the ending of child sexual abuse, it has to come from adults who choose to get educated and choose to be more aware, versus, I think predators thrive on the secrecy and the darkness of it, versus it being brought into light, so that we are more aware and we are more equipped to
Yes,
see, to handle, to prevent things like that. So I will be sure to put in the show notes all of the different resources that you've recommended, including the documentary that you have as well, for folks to
appreciate
get
that.
involved in, to support, and to be able to learn from. So thank you very much, Dr. Brewerton.
All right. Thank you, Laura. Take
Okay.
care.